Welcome everybody to today's session. Today's session is from the surgical ICU, St. John's Medical College, Bangalore, and it's a surgical intensive care today for a change. We haven't discussed surgical intensive care for some time. So a surgical case will be presented. It will be presented by a senior resident in surgical ICU, Dr. Anne Lucas, and the moderator will be Dr. Vikram. Dr. Vikram is associate professor in anesthesia and critical care in surgical ICU, and the surgical inputs will be from Dr. Jiju Mohan. Dr. Jiju Mohan is assistant professor in surgery. He was looking after the case along with the other people. So over to you, Dr. Ann, for rendition, and Dr. Jiju to move the slides. We'll take each slide as we go on. Huh? Okay.
So good evening, everyone. So I'm presenting a case of acute abdomen. So the patient is a 63-year-old male who is a resident of Andhra Pradesh and is a farmer by occupation. He presented with a 3-day history of abdominal pain, 3-day history of fever associated with constipation, 1 episode of vomiting, and a 1-day history of decreased urine output. So going on to the history of present illness, he had intense dull aching pain, especially over the upper abdomen, which was exacerbated with movement or coughing, which was not associated with, which had no change with food intake, and it was associated with progressive abdominal distension, which worsened over the 3 days. He had 1 episode of vomiting, which was non-projectile, non-bilious, contained food particles and was not blood-stained. 1 episode of fever 2 days ago, which was high grade, not associated with chills, and which subsided on medications. Patient has been also been having constipation and obstipation for the last 3 days, and he complained of decreased urine output over the last 1 day just prior to admission. There is no history of jaundice, weight loss, use of NSAID, use of corticosteroids, recent travel, no history of breathlessness, cough, syncope. He had no history of any peripheral edema or facial puffiness also. He was
okay, just go back to the history now. Huh? Okay, so what is the summary of the history, Dr. Ann?
So 63-year-old male with a history of 3-day history of abdominal pain, fever, vomiting, along with constipation and obstipation, with a decreased urine output of 1 day duration.
And he is alcoholic and he is a smoker, right?
Yes, he is an alcoholic and smoker.
And hypertensive and diabetes. Huh? This is a very important things.
Yes, I think a few slides were missing in between, the one with past history and...
The missing or what?
It's all right.
I've already showed this, I think.
Past history, yes, sir.
So he is a non-case of diabetes and hypertension for the last 2 years on tab amlodipine and OHA, but he has not been compliant with medications. Personal history, he is a chronic smoker who smokes around 5 to 6 cigarettes per day for the last 20 years, and last smoke was 5 days ago, and history of occasional alcohol consumption, last drink 1 month ago.
Okay, so does he become alcoholic?
Yes, sir.
Actually, you know, alcoholics never say they drink regularly. Even if they are drinking heavily, they will give only this kind of history. You have to assume they are alcoholics, huh?
Yes.
Go back to the history. Go to the second slide now. Dr. Jiju Mohan, how do you evaluate pain in the upper abdomen here? What are the possible causes and approach to such a patient? You know, the main complaint is upper abdomen pain. So, Dr. Jiju Mohan, how would you approach this upper abdominal pain in terms of differential?
Yes, sir. So most of the patients, elderly age group, most of them will be that burning, this one, so gastritis kind of thing. And the other one will be this one, so chest pain, so MI related one. So usual first thing, elderly age group, we'll ask for a ECG in the EMED, it's a casualty itself. And also at the same time, we'll start him on some IV PPI also. So by the time you'll be able to know, and then we'll examine the patient also, like where exactly is the pain, guarding rigidity, anything is there. Depending on that, we'll decide we have to go ahead with an X-ray or a USG abdomen.
So I think that is very important point that you have made, that is diabetic, hypertensive and elderly, and MI has to be considered. You know, this is a very, very important point. Upper abdominal pain, MI sometimes come as upper abdominal pain. Risk factors is diabetic, is hypertensive, is elderly. So this is a very important point. ECG should always be done. Now, That is one thing which is ruled out. Referred pain from extra abdominal conditions can lead to upper abdominal pain. Supposing the pain is appearing from an abdominal structure, so the approach would be to consider the structures in the upper abdomen, right?
Yes, sir. So again, we'll ask for the history of any recent alcohol intake, like we are suspecting any pancreatitis. So we have to send for amylase lipase also.
Okay, pancreatitis, acute pancreatitis is one. What else lies in upper abdomen which can cause pain?
Yes, sir. Then this one, sir, like if it's an elderly age group who is on NSAIDs, and some patients who is on antiplatelets, steroids, or this one, like yes, antiplatelets and all already is a cardiac patient who's on NSAID plus steroids and antiplatelets. We have to consider the diagnosis of a perforation also, and also take history of any previous.
Perforation where?
In the duodenum, sir, or like any history of any peptic.
No, if there is no NSAID history, can he have duodenal perforation?
Sir, sorry, sir.
There is no NSAID history. Can he have duodenal perforation?
Yes, yes, sir. Like usually it's rare, sir, but still.
No, it's not. It's not that rare. You can
Yes,
have pylori. You know, H. pylori causes a lot of duodenal and gastric ulcer.
Yes, sir. But nowadays, because of better use of PEPIs, compared to before, perforations are a little more lesser.
Okay, so we have duodenal perforation. We are gonna have acute pancreatitis. What else can cause acute abdominal pain like this?
Yes,
Also, you know, he's got fever, urine output is decreased, so he's a sick patient. So what other conditions? What structures lie in the abdomen which can cause pain, acute abdomen pain, upper abdomen?
So even this one, sir, any acute this one, cholecystitis also sometimes.
Very good. Yes. Yes. What else?
Then
so the other things, one acute cholangitis. If you're saying acute cholecystitis, then it can be acute cholangitis also.
Yes, sir.
Then we have to look at the liver. The liver
Yes.
can get amoebic liver abscess or pyogenic liver abscess.
Yes, sir.
The alcoholic patients are predisposed. Elderly alcoholic patients are predisposed.
Yes,
Then
sir.
you said gastritis. What kind of gastritis can you get, which can cause acute abdomen pain like this? There is an entity called phlegmonous gastritis.
Yes, sir.
It is not just a usual kind of gastritis that you have some burning and all acidity kind of a thing. You know, these patients are sick and it's an infection, bacterial infection or severe viral infection of the stomach leading to a phlegmonous gastritis. The stomach distends and you can actually see a huge gastric bubble on the X-ray and the diaphragms go up.
Yes,
So,
sir.
not phlegmonous. It's not common, but it occurs. Right? It can cause an acute abdomen-like condition. It's not the usual garden variety of gastritis. Then
Yes, sir.
to consider, you know, some kind of viral gastroenteritis also. Something that can cause severe abdominal pain without diarrhea. Diarrhea is not necessary. They can just have vomitings and upper abdominal pain. And then, of course, what about the transverse colon? Anything in the transverse colon which can give rise to this?
Yes, any malignancies, any this one's other intestinal disease like sometimes even Crohn's disease, ulcerative colitis also they'll come to you with pain abdomen, vomiting, those kind of histories. Sir.
Yes. Okay. So I think that is the kind of differential that we are considering. This should be one of this, and MI is also possible. So the other thing she has mentioned is the abdominal distension.
Yes, sir. Yes.
Now, in a patient who is presented with acute abdomen, why should there be upper abdominal distension?
So, following any perforations, this one, so if any peritoneal leak is there, that causes the chemical peritonitis. Like initially, it will be the gastric juice which is going out and causing the chemical peritonitis, and later even the bowel contents can go inside and cause the peritonitis. So again,
why does peritonitis lead to abdominal distension?
Because again, this one, so there is that fluid phase loss. All this happens, and that causes paralytic ileus, and all this leads on to.
Okay, so you get fluid collection in the peritoneal cavity, and there's ileus,
Yes, sir. Yes, sir.
One is perforation can lead to abdominal distension because of peritonitis.
Yes, sir.
So what other causes can lead to abdominal distension in terms of physiology, pathophysiology of the GI tract?
So again, this one's any electrolyte imbalance also sometimes which causes ileus, and again they'll come to you with constipation. And like sometimes even it will
okay, ileus, some conditions, whatever conditions, ileus can lead to abdominal distension. What?
Yes, and sometimes even stroke patients or like chronically bedridden patients also.
No, let us stick to the case.
Yes, sir. Yes, sir.
No stroke here. So what else? Ileus and peritonitis, then intestinal obstruction.
Yes, sir.
Intestinal obstruction.
Yes, sir.
And sometimes if there's constipation, there can be a lot of flatus and gas accumulation in the bowels.
Yes, sir.
Severe constipation can also lead to abdominal distension.
Yes, sir.
What we are dealing with here,
Yes, sir.
abdominal pain with distension. Now the urine output has decreased. Okay, so Dr. N, why do you think the urine output is decreased?
So one reason is probably the patient must have had a lot of third space loss, and the hypovolemia and prerenal AKI would have led to the decreased urine output. Or
Are you sure there is prerenal AKI?
I'm sorry, sir.
Are you sure there is prerenal AKI?
That is one possibility. Another
Okay.
possibility is because of the sepsis that could have caused an acute kidney injury.
We do not know whether there is sepsis. What is the evidence for sepsis there?
He has been having a 3-day history of fever.
Was the fever documented? These people always say they have fever. Whenever they are sick, they say they have fever. To say actually fever, you should always ask whether the fever was documented by a thermometer. They always say they have fever because they're ill. So, you know, they're not well, they'll be feeling warmish, or not well, they will say they have fever. Fever, whenever one takes the history of fever, always ask was the fever ever recorded. This is very common. And when you ask them, they will say fever was not recorded. When you take the temperature, when the nurse takes the temperature, there will be no fever in the ICU. So the history of fever has to be taken with a pinch of salt. We do not know if there's any sepsis or no sepsis. Okay. So urine output
dehydration is one possibility because
okay, I agree. It's possible there's a hypovolemia. So whatever, if there's intestinal obstruction, there can be accumulation of fluid. If there's peritonitis. So let us see. And he's having vomiting. His intake is poor. So it can be pre-renal. I agree. Now, what is non-projectile vomiting, Dr. Ann?
The one which is associated with nausea and usually seen in abdominal.
The history, no, we always take the history, non-projectile, and we are taught always non-projectile. And also, what is the difference between projectile and non-projectile?
Projectile vomiting is seen in conditions like raised ICP, where vomiting occurs without any preceding nausea like symptoms.
Very good. So that is one of the main differentiating point, that projectile vomiting is associated with ICT or any situation where there is no nausea. But the main condition is ICT. It can also occur with gastric conditions. Suppose you take some poisons and all, certainly there will be irritation and you can have a projectile vomiting. The other thing is it's supposed to go very far, but that is a very subjective thing. The main thing is there's no nausea in projectile vomiting, and it is an indicator of ICT raised. And it can also occur with GI conditions. So that is the key point about projectile and non-projectile. Now, we were considering the differential. So let us assume he had fever and he has pain abdomen, right?
Yes.
Now, can this be any infectious process?
It can be a urinary tract infection because he's been a diabetic who has not been.
Upper abdominal pain will not occur in urinary tract infection. That's the key symptom.
Yes, it could be a symptom of diabetic ketoacidosis. Or
diabetic ketoacidosis. So why does pain occur in diabetic ketoacidosis? It occurs because of ketones. That's a difficult question. So ketones, the elevated ketones interact with the intestinal mucosa and they cause the pain abdomen. So the two infections that can be considered here is one enteric. Enteric causes perforation.
yes.
Common enteric perforations. However, it's too early. Normally, enteric perforations occur later in the course of illness. The second differential is leptospirosis. You know, leptospirosis is a disease which is associated with fever and jaundice and decreased urine output, and also it can cause abdominal pain and rigidity because it affects the muscles.
Yes.
Leptospirosis is known to affect the muscles. CPK becomes high in leptospirosis, and sometimes these patients have a tender guarded abdomen. So that is another differential that we can consider. Okay.
Yes.
So now carry on, Dr. Jijumon. Next slide.
So the patient was initially evaluated at an outside hospital and then referred to our hospital for further management. The initial evaluation at emergency medicine showed that the patient had tachycardia of 120 per minute. Saturation was 95% in room air. BP was stable, 120/70. Respiratory rate was 25 per minute. Abdomen was distended and there was guarding and rigidity. Bowel sounds were sluggish and patient had bilateral rhonchi.
So why did he have rhonchi?
He is a chronic smoker, so he can have an underlying component of COPD.
Okay.
Or a lung infection.
Now the saturation is 95% on room air. Is that consistent with COPD diagnosis?
No, sir. No, they can have a.
Is that consistent or not consistent?
That is that can be there, sir, because
Yes.
that is.
So that can be there. You know, the hypoxia and hypercapnia come later. Actually, if the patient is not having advanced COPD, he can have only rhonchi, but ABG and the gases can be normal. Okay. Now, one thing you have not told here is distending and rigidity is where? Where is the guarding and rigidity?
It's mainly in the epigastric and umbilical region.
So that is very important, you know, where is the guarding and rigidity? Because that localizes the part of the abdomen where the pathology is.
Yes.
So that is very important. Okay. Now, carry on. Next slide.
So the patient was shifted to ICU after starting a fluid resuscitation and a general surgery consultation. On arrival in ICU, he had a tachycardia, heart rate of 136 per minute, afebrile. He had bilateral pitting pedal edema, grade 2 clubbing. Oral cavity showed a corded tongue. Abdomen was distended, and he had tenderness in the epigastrium as well as bilateral upper quadrant.
Okay. So now, you know, you have said, why is he having bilateral pitting edema?
He had a decreased urine output for the last 1 day. So there is a possibility that the acute kidney injury and the overload status.
So pre-renal azotemia will have pitting edema.
Usually in pre-renal, the patient is dehydrated and there is no.
So it is not because if it is in pre-renal, it cannot be because of that.
Yes.
In ATN, right?
Yes.
So okay, one reason is if he's in ATN, but it is unlikely that he's in ATN. Even if in ATN he's dehydrated, there's no history to suggest fluid excess. He's not received IV fluids.
Yes.
Having pedal edema. Who has seen the pedal edema? You have seen?
Yes, sir. There was edema.
There was edema. Okay. So the albumin was normal. He's an alcoholic.
Yeah, he is an alcoholic. Albumin was slightly. Albumin was borderline, sir. 2.7. 2.8
is low.
It is low.
2.7.
Yes.
Yes,
sir.
So that is the cause of pedal edema. That albumin is low. 2.7 is a low albumin. Other reason is he's on amlodipine. Amlodipine causes pedal edema.
Okay.
Can be other reasons. Okay, he may be having congestive heart failure. You don't know, he's diabetic, hypertensive, elderly.
Yes.
And you know, maybe something else. So one thing is you have said albumin is 2.7. Now why he's having clubbing also? You have written why is he having clubbing?
He's a chronic smoker.
No,
so
smoking does not lead to clubbing. COPD patients don't get clubbing unless they have bronchogenic carcinoma. Are you sure he had clubbing?
Yes.
It's not so easy. I mean, okay, let us leave the clubbing aside, but the one condition, COPD does not lead to clubbing. If a COPD patient is getting clubbing, you have to think either he has bronchiectasis or bronchogenic carcinoma. And clubbing occurs in ulcerative colitis also. So if he has ulcerative colitis leading to all this, then that can be associated with clubbing. Okay?
Okay.
So now you have said oral cavity, tongue coated. So what is the significance of coated tongue?
Dehydration.
No. So since this coated tongue comes from ages, from the 1900s, when coated tongue was associated with enteric fever and all, and it is carrying on. So really does not have any significance anymore. The only what is relevant to us as intensivists or people who look after critically ill is coated tongue can be Candida.
Yes.
Tongue can be Candida. So that is very important. When you look at a tongue which is coated, think of Candida. Of course, it can occur in other conditions. There's no significance. It is just carrying on from 1900, 1920, when there were no real tools to decipher things. Some of these things just carry on in the textbooks. Huh? Okay. So that is about the examination. Now the blood pressure is 116/70. Do you think this is a normal blood pressure for him?
He is a non-hypertensive, so for him, this may be on the lower range.
So
And
can this patient be in shock? Can you call him as
yes,
in shock?
because there is significant tachycardia along with the borderline BP. So
BP is not borderline, it is 116/70.
So because he is a
So what is the
non.
definition of shock?
So there is
In terms of blood
compromise
pressure. In terms of blood pressure.
in a map of less than 60, which would compromise the perfusion of
Okay.
endolets.
And what is the other blood pressure definition? So if the patient is hypertensive, a fall of 40 from baseline is also considered shock.
Okay.
So if his pressure is uncontrolled, blood pressure is non-compliant with medication, he's a farmer, you don't know what his baseline blood pressure is. If he's having a blood pressure of 150, 160 as a baseline, a drop of 40 is shock. So this patient can be in shock. Huh?
Yes.
Okay. Okay. Next slide.
So on per rectal examination, the rectal tone was normal, no melena, and on auscultation, bowel sounds was sluggishly heard. Respiratory system, there were respiratory rate was around 28 per minute and saturation of 94 to 95% on room air. The bilateral chest movements were normal and the shape of the chest was barrel shaped. And there was bilateral rhonchi over infraclavicular and axillary region.
Okay. So next slide.
So in CVS, JVP was normal, S1 and S2 were heard normally, and there was no left parasternal heave. CNS patients was conscious oriented and motor system and sensory system grossly, the examination was within normal limits.
Okay, next slide. So Dr. Vikram, you want to add anything at any point? Dr. Jijumon, you want to add anything? Please feel free. Huh?
Yes, sir.
So the differential diagnosis, because the chest X-ray showed air entered. So the differentials at this point was hollow viscous perforation with peritonitis, acute intestinal obstruction, mesenteric ischemia, acute pancreatitis, acute cholecystitis, urinary tract infection, diabetic ketoacidosis, uremia, or myocardial infarction.
Okay, so now looking at the differential diagnosis, your number one diagnosis is hollow viscous perforation with peritonitis, with which I agree, because there are signs of peritonitis and rigidity. Huh?
Yes.
And peritonitis generally results from perforation when there is guarding and rigidity. Acute intestinal obstruction can also lead to some degree of peritonitis, but guarding and rigidity would not be there, and there will be a lot of vomiting and distension. Acute mesenteric ischemia does not have peritonitis in terms of guarding and rigidity, and the abdominal examination is generally unremarkable to a great extent, and pain is very severe. Acute pancreatitis, again, there is no peritonitis, and pain is quite severe in acute pancreatitis. Acute cholecystitis, again, unless there's a perforation or some leakage, you won't get peritonitis in terms of guarding rigidity. UTI is out because it's upper abdominal pain. Diabetic ketoacidosis again would not lead to peritonitis, and we have to look at the sugars. What is the admission sugar?
It was 206, not.
So unlikely again. UTI is more of a theoretical concept. Actually, it causes gastritis, which can cause pain. That is how it causes abdominal pain. And myocardial infarction is unlikely because you have abdominal signs. So
Yes.
this is the reason why actually hollow viscous perforation with peritonitis is most likely. So any comments, Dr. Jijumon, on the differential?
Yes, so like if you are talking about in this case, we are suspecting a perforation. So usually what happens is with less than 2 hours, usually the triad will be there. Patient will suddenly have tachycardia, they'll have severe abdominal pain, and on examination, they'll have that guarding kind of thing. And if it's between around 2 to 12 hours, usually the slowly first that gastric juice will be coming out and then the bowel content. And if the patient is moving also, because of the collection in the right paracolic triangle, they'll have pain in the lower abdomen as well. and again they'll be having guarding also. And if it's more than 12 hours and still if they're not taking any treatment, then they'll have distension also because of the paralytic ileus, and then they'll start having fever as well. And again, they go into shock, like hypertension also will be setting in.
So, Dr. Vikram,
Yes, sir.
to comment, what
Patient had obstipation. So, is obstipation a sign of peritonitis, Dr. Gigi?
Yes, again, because of peritonitis, again, sometimes patients, the bowel movement won't be there. So that can also go into obstructions. So like this patient is having, because he's an elderly patient also and diabetic also. So mostly he was not recognizing his pain. And sometimes these laborers, farmers, and their pain threshold is also a little more. So usually they'll come to you with at a very later stage.
Okay.
So, perforation with peritonitis. So anything else can cause such kind of peritonitis with guarding or rigidity apart from perforation?
So in pancreatitis also, or if any cholecystitis with the perforated this one gallbladder with
So
the bile.
the perforation has to be there to cause such guarding and rigidity, right?
Yes, sir.
So now one is you can have a gastric ulcer or a duodenal ulcer perforation. Anything else can perforate?
So any other large bowel, this one's a tumor which is gone into obstruction and perforated.
Okay. What else?
And sometimes in even pancreatitis also, sir, because of the excessive this one's amylase, like this one pancreatic enzyme leak also. Sometimes they'll have severe pain like this, like they'll go into peritonitis.
Pain, the perforation is not a feature of pancreatitis. So enteric perforation, enteric perforation can be there.
Yes, sir.
And sometimes, perforation. What else can cause perforation? Tubercular ulcers, common things in India.
Yes, sir. And this one's a Crohn's disease, ulcerative colitis.
Yes. So, but tuberculosis history is not there. Apparently, was well. An enteric 3 days fever is not enough to cause perforation. Normally, they come later. But sometimes the history is not forthcoming. For fever may have been going on for some time. Enteric perforation is very common. At least I have seen a lot of enteric perforation.
Yes, sir.
Okay, fair enough. Next slide.
So routine blood investigations were sent. Total count was 7,600. With the thrombocytopenia, platelet count of 88,000. Serum blood urea was elevated 143. Creatinine was 3.03. PT-INR was normal. LFT except for the albumin enzymes, the liver enzymes were normal.
Next slide.
Amylase and lipase were also normal. RBS was 189. Serum procalcitonin was 41, that is elevated.
So last slide, previous slide, please. So why is the TLC normal? Is it compatible with what we are having here? If you are thinking DU perforation and peritonitis, is the TLC normal, Dr. Anne?
There should have been leukocytosis or leukopenia considering the sepsis picture we are having here.
Can you have a normal TLC in sepsis? You can have a normal TLC. Yeah? A lot of patients have a normal TLC. Now, why is the platelet count low?
So this could be sepsis related, or he's a chronic alcoholic with alcoholic liver disease that is causing the thrombocytopenia.
Okay, very good. So alcohol is a cause of low platelets. Alcohol because of alcoholic liver disease, or sometimes alcohol, even if there's no liver disease, alcohol suppresses the marrow. Alcoholics have a low platelet count. That is one condition which can lead to low platelet. Anything else can cause thrombocytopenia here?
If you're considering a diagnosis of viral fever or a leptospirosis, as you mentioned earlier, a dengue fever or a leptospirosis, if that was the reason for fever, there can
that is okay. That is not a diagnosis here because other features are not there. Your LFT is normal, but you said albumin is 2.7, so that is not a normal LFT. LFT, we should always write the details of LFT because what we think is normal may not be normal. So there's a hypoalbuminemia here, and if there's a hypoalbuminemia, though the INR is normal, I do not know. He may be having chronic liver disease because hypoalbuminemia and high INR is a feature of chronic liver disease. And if you have a chronic liver disease, the patient is so sick, you can go into acute or chronic liver disease also. So one has to look, he's alcoholic. Once the patient is alcoholic, liver becomes very important. Okay.
Yes.
So the low platelet count can be because of sepsis. If the patient is in sepsis, that can lead to low platelet count. Huh?
Yes.
So the platelet count become low in sepsis, Dr. It because of DIC, one. And even if there is no DIC, there is increased consumption, destruction, and decreased production of platelets in sepsis because of cytokines. Now you said the patient was in pre-renal AKI. Is there anything in urea creatinine to suggest that he has pre-renal AKI?
So there is both the urea and creatinine has been elevated. We do not have a baseline value of the creatinine, but still the urea is 143 with a creat of 3 along with the decreased urine output.
So does that help in making any diagnosis in terms of pre-renal AKI or ATN? Have you heard of urea creatinine ratio?
So the elevation in urea is much more compared to that of creatinine here. So
Dr. Vikram, you like to comment anything on blood urea creatinine ratio for differentiating pre-renal from ATN? So, if the ratio of blood urea to creatinine is more than 40, that is in a young patient, it is highly suggestive of pre-renal. A ratio of urea creatinine more than 40, and if it is less than 20, that is in favor of ATN. So, in a patient without pre-existing renal disease and not on any diuretics, etc., it helps in differentiating with the sensitivity and specificity of around 90%. So that is small, it's a very simple test. This patient likely had pre-renal, not 100% sure. You can get this ratio even with ATN sometimes, but generally it's like this only. Next slide.
The amylase lipase were normal and procalcitonin was elevated.
So amylase is normal, it increases in pancreatitis, it is not increased. Can amylase increase in DU-perf?
Yes, because it's right behind the like duodenum. Sometimes the perforation can be closed by the this one's pancreatic wall also. So sometimes the initial part the perforation can be a sealed perf also, and those cases again that can cause a mild increase in amylase.
Okay, so procalcitonin is 41. So Dr. Vikram, you'd like to comment on procalcitonin?
Yes, sir. Procalcitonin is a sepsis marker, mainly indicates gram-negative sepsis. But there are other conditions where it can be elevated. You can have a false positive elevation of procal. But main is if you look into the trends, and if the trends is showing a change, then it goes in favor of sepsis.
Okay, so serum procalcitonin raised here is in favor of sepsis. However, serum procalcitonin is never recommended as a necessary tool to diagnose sepsis. As per the sepsis guidelines which have come up recently, you can have a normal procalcitonin in sepsis, or you can have an elevated procalcitonin. And it does not really help to diagnose or rule out sepsis. However, in the setting that we have, it is likely that there is sepsis, or even SIRS can lead to a raised procalcitonin. The utility of procalcitonin is to follow trends. And when you follow trends, if the patient is improving, a patient of sepsis is improving, then procalcitonin will keep decreasing. And if there's a sudden rise, something has happened, either a nosocomial infection has set in or some other catastrophe has occurred. The other thing is, once procalcitonin has reached 80% of its admission value, there it can help you to switch off your antibiotics, stop the antibiotics. But procalcitonin, it can be normal in sepsis, it can be raised in many conditions besides sepsis. So it is not really a useful tool to diagnose sepsis, but like you said, one can follow trends and it helps in stopping antibiotics also. Okay, so here probably the patient has sepsis or patient has SIRS without sepsis. Is very difficult to say. Next situation.
So the ABG, On admission showed acidosis with a pH of 7.15, PCOT of 39, POT of 70, bicarb was 12.9 with a lactate of 4. So there was
Yeah, carry on.
metabolic acidosis and increased lactates on the ABG.
So this is metabolic acidosis.
Yes.
And what was the anion gap? Is it an increased anion gap or a normal anion gap?
Sir, on this, the anion gap was normal, sir. High anion gap was not there. I've not mentioned.
So what is the formula for anion gap?
So the sodium, potassium is calculated, and the negatively charged and positively charged electrolytes, the difference is taken.
No, you tell the formula. Simple formula. How do you calculate an anion?
Sodium, that is a positively charged, minus chloride and bicarbonate.
Okay. So what are the causes of increase in anion gap? Three simple causes.
Diabetic ketoacidosis, methanol,
Okay.
salicylate poisoning.
Okay.
Normal anion gap acidosis is
No, increase the anion gap.
increased.
What about lactic acidosis?
Yes. Lactic acidosis also it is.
So what is the lactate here?
It is 4.
So is it likely to be increased or normal anion gap?
It is high, sir. It is increased anion gap.
One should always mention anion gap also. So sodium minus chloride minus bicarbonate. So
Yes.
it's likely to be increased anion gap. So the diagnosis of ABG is metabolic acidosis. Huh?
Yes. Yes.
Right? Compensated or non-compensated?
This is non-compensated, sir. Bicarb is decreased, but still the pH is 7.1.
So when do you say it is compensated?
When the pH remains between 7.35 to 4.5 with reduced bicarbonate.
Do you look at anything else or you only look at the pH?
The base deficit also.
Anything else?
PCO2.
PCO2 is the major thing, no? PCO2 will compensate.
Yes, sir.
PCO2 will go down or go up to compensate?
So in metabolic acidosis, PCO2 will come down to
So why it is not coming down here?
He is an COPD patient, so maybe he had a hypergarbia and this is low for him actually. So that could be a possibility.
That is possible, but here it is unlikely because room air saturation is very. So, first there has to be hypoxia, then only there is hypercapnia. You are right, he has COPD. So COPD patients are already, they have respiratory distress in terms of respiratory muscle fatigue, and he's in relative hypotension or hypovolemia, and he has acidosis. So muscles are weak already. So probably he's not able to compensate. He's not able to increase his minute ventilation.
Yes.
It is not compensated. And for compensation, you have to look at PCO2, not at pH or anything else. The compensation is by. Huh? Okay.
Yes,
You want to add, Dr. Vikram?
Yes, sir. That's what here it is uncompensated. It's not compensated, or maybe he's not able to compensate completely. It's uncompensated metabolic acidosis.
Yeah, with increase in iron gap.
Yeah.
Okay. Lactic acidosis is there. So why?
Yeah, this increased lactates may not be always associated with acidosis. As long as lactates are metabolized, that shouldn't contribute to the acidosis. Especially they say lactates of more than 5 is significant. Lactates of more than 5 associated with drop in pH is lactic acidosis, pH of less than 7.3. So we don't know whether it's here it is lactic acidosis or a normal anion gap acidosis.
You see, once lactate is increased, so it is the anion gap is likely to be increased. It may or may not be increased. That you are right, but more likely it is to be increased. But if you go beyond 4 or 5, then the anion gap has to be increased in lactate. With the lower level, you are right, it may or may not be increased. And there are many reasons for that. It is a little complicated, but sometimes the lactate levels do not exactly correlate with the anion gap and the pH. So you are absolutely right there. I agree with you.
Yes.
Next.
So imaging chest X-ray showed air under diaphragm And bedside screening echo was done, which showed a good contractility with no RWMA and normal chambers.
So there's air under the diaphragm. So Dr. Jiju, what all can cause air under the diaphragm?
So usually any perforation, sir, it can be gastric, duodenal, or any other bowel perforation, which causes the air under diaphragm. But sometimes even in duodenal perforation, it can be a sealed off perforation because it will be very small perf, and because of the pancreas pressing on over there, sometimes there won't be any this also like perforation as such. There won't be any air under diaphragm also. So in initial phases, if you take an X-ray,
perforation can cause. What else can cause? Okay, Dr. Vikram, any comments?
I think perforation is the most common cause, sir.
Okay.
Other causes, can we, Dr. Jiju, can we have it in a post-op patient who has undergone a laparoscopic surgery?
Yes.
Pneumoperitoneum, is it possible?
It's possible, sir.
Possible.
Yeah, so Dr. Vikram has hit the nail on the head. It can be seen post-operatively. You know, when you open the eye for up to 3-4 days, you can have gas under the diaphragm sometimes, and in laparoscopic patients. And sometimes, you know, even if the gas-producing organism, there's free gas production. And sometimes, you know, if there's pneumometastasis, there's air in the thorax, it comes down into the peritoneum, and you can have gas under the diaphragm. So there's a differential for gas under the diaphragm. You know, the patient gets operated, and you do an X-ray, after 3-4 days, and you see gas in the diaphragm. So that can happen because of the surgery, or just the surgery. It doesn't have to be a perforation. This happens occasionally. So one should be aware of the conditions which lead to air under the diaphragm. Okay, great. Next.
So this is an approach to the diagnosis of a case of acute abdomen. So when there is tenderness in any aspect of the abdomen, the first thing is imaging and upright chest X-ray, ECG to rule out any referred pain, then routine investigations like CBC, amylase, lipase, LFT, serum electrolyte RFT. If there is a palpable mass, that would indicate further imaging with a CT abdomen or pelvis. If there is a free air under diaphragm, the most common cause is perforation, and it would warrant a surgical consultation. If the ECG is abnormal, cardiologist has to be involved to rule out any acute ischemic changes. If amylase or lipase is elevated, that could signify a pancreatitis. So imaging of liver, gallbladder, and or CT of the whole abdomen. If all the basic investigations are normal, to rule out a hepatobiliary or pancreatic pathology, ultrasound abdomen or endoscopy has to be done.
Dr. Jiju, this air under diaphragm, does it correlate with the site of perforation or size of perforation?
No, sir. The site doesn't correlate, sir. But size can be made out. If there is a large perforation, then there will be the amount of air will be more.
Okay. Suppose a perforation in the ileum or colon lower down, still can we have a, and is it 100% sensitive? I mean, do all perforations have air under diaphragm?
Yes, sir. Only in case sometimes because the omentum can come and get stuck over there. So sometimes that will cause, but still, if there is a small amount of perforation also, usually you can make out in the X-ray, like air under diaphragm will be there. Only in the initial part, if the air amount is less, you can miss it in the X-ray. So those cases, we'll advise for a CT, depending on the patient's clinical examination.
So absence of air under diaphragm does not rule out perforation?
Yes, sir.
Okay.
So the other thing is, you know, to acute abdomen tenderness. So sometimes there may not be tenderness. Patients who are elderly, who are extremely diabetic, multi-organ disease, immunocompromised, there may not be tenderness, and signs and symptoms may be very subtle. Am I right, Dr. Jiju?
Yes, sir.
So here, you know, it can be difficult to pick up pathology.
Yes, sir.
Okay. So should we move on to the next slide?
Yes, sir.
So again, the differentials would be pain originating in the abdomen or a referred pain from outside the abdomen. So originating in the abdomen could be due to peritonitis or obstruction or perforation of a hollow viscera, vascular disturbances like a mesenteric angina, or any causes, any soft tissue lesions of the abdominal wall. Referred pain from outside the abdomen would include a torsion testis, MI, or pain of herpes zoster. Other metabolic causes like uremia and decay are also a possibility. But those won't be associated with any abdominal signs.
Okay. Next slide.
So on admission to the ICU, the working diagnosis was hollow viscous perforation with peritonitis in prerenal AKI and sepsis.
So now the diagnosis there, hollow viscous perforation, we have seen here under the diaphragm, fair enough. And upper abdominal pain, so likely to be from the duodenum or from the gastric ulcer, or there is a prerenal acute kidney injury and there is sepsis. So Dr. Vikram, you are happy with the diagnosis of prerenal acute kidney injury and sepsis, or you think sepsis can be further qualified into either septic shock or something?
Yes, sir. Since, as you mentioned earlier, patient could have been in shock. We don't know. He is a hypertensive. So could be septic shock and DIC. We can add the diagnosis of DIC since he has thrombocytopenia. Along with that, hypoalbuminemia also could be a part of the diagnosis.
So you see now sepsis, it could be sepsis or it could be septic shock. But to say septic shock, one has to give fluids first. 30 ml per kg has to be given. So, what is the definition of sepsis? Dr. Ann, you know the definition of sepsis? So sepsis is defined as new onset organ dysfunction with an increase in SOFA score of 2, assumed to be because of an infection. Okay, so here your renal injury is occurring, the thrombocytopenia is occurring, so your SOFA score is increasing, and you presume there is peritonitis, so there's an infection. So sepsis is very likely here. Now, after there is sepsis, there's an entity called sepsis-induced hypoperfusion. So sepsis-induced hypoperfusion is a condition in which there is hypotension, there may be lactic acidosis, and this condition is responsive to fluids. If the hypotension responds to 30 ml per kg of fluids in the next 3 hours, then it is called sepsis-induced hypoperfusion. Okay. Now, if this does not respond to fluids, then it is called septic shock. Then it is called septic shock. So we have not come to the stage where fluids have been given. We are still looking at the history examination and investigations. So he may be in sepsis, he may be in sepsis-induced hypoperfusion, he may be in septic shock. Shock, like we discussed, there might be a relative shock here because he's hypertensive. And the lactates are increased. So any comments on the lactates, sir, Dr. Vikram, why the lactates are increased?
So lactates, cause of increase in lactate could be either it's because of increase in the production or decrease in the clearance. Here it looks like since considering the decrease in the urine output and all, and it could be because of reduced perfusion. So shock could be the cause of increase in lactates. Other thing could be it could be a known CLD because of his alcoholic liver disease. He's a known alcoholic. So decreased clearance of lactates also could have resulted in so hypoperfusion and also some amount of hepatic dysfunction and renal dysfunction could have resulted in increased lactates.
So renal dysfunction contributes to some extent because some amount of lactate is cleared in the kidneys also.
Yeah, majority of it is in the liver.
Yeah, 20% is cleared by the kidney approximately, 30% in the liver, but we do not know whether he has chronic liver disease. But like you said, it's most likely because of shock and hypoperfusion. The other thing is he's in sepsis, right?
Yes,
to be in sepsis, so sepsis itself, even if the patient does not have hypoperfusion, sepsis by virtue of its cytokines and maldistribution of blood flow in the capillaries, microcirculation can lead to hypoperfusion and alteration in the glycolytic pathway.
Yes.
The glycolytic pathway leading to lactate production. Okay.
Yeah, sepsis has more than one mechanism where lactates can go high.
Yes. Other thing is he's alcoholic, so he may be thiamine deficient also. He may be thiamine deficient. Now the question comes into play is whether lactate is necessary for the diagnosis of septic shock. So, Dr. Ann, is high lactate necessary for the diagnosis of septic shock?
No, sir. No.
Okay, very good. So earlier lactate was necessary for the diagnosis of septic shock, but the Surviving Sepsis Campaign guidelines published around, it's been some time now, 8-9 months, do not make it necessary that lactates be increased. Around 10 to 15% of septic shock patients do not have a increased lactate. Though lactate levels correlate with prognosis. Higher the lactate, worse the prognosis. And lactate clearance is also important in these patients. Patients who clear the lactates in the first 8 hours have a much better prognosis than those patients who do not clear the lactate. Ultimately, lactate is used as one of the points for giving fluids, but it cannot be targeted that you keep giving fluids till the lactate normalizes. Like Sir has said, Dr. Vikram has said, lactate clearance may be impaired. If he has liver injury, the lactate will not fall to normal levels. If he has renal dysfunction, lactates will not fall to normal levels. If he has thiamine deficiency, lactates will not fall to normal levels. So you cannot target lactate levels to normalization and keep giving fluids. That is the thing about lactate. Okay. So now coming to your pre-renal acute injury. So what other diagnosis can be there for the kidney injury, elevated urea creatinine?
Sepsis related acute tubular necrosis.
One is pre-renal, one is sepsis induced acute kidney injury. Anything else? So what other renal diagnosis can you get with hypovolemia and hypotension? ATN. Pre-renal, if it's not pre-renal, then it goes into ATN. So yeah, it can be pre-renal. Pre-renal is reversible. Reversible. So the pre-renal factor, if it's not corrected, it goes into ATN. And the other thing is septic AKI. And we do not know whether he has received any drugs. He's been evaluated outside. Whether they gave him any drugs, I don't know. So drugs are a very important cause in the ICU. They get aminoglycosides, they get penicillins, that can lead to renal failure. Next slide.
Next slide.
So the etiology of hollow viscous perforation, small bowel, an erosion from duodenal ulcer, tumor, infection or abscess which can perforate, a Meckel's diverticulum, or a strangulated hernia, inflammatory bowel disease, mesenteric ischemia, when the damaged bowel following ischemia, it can perforate, a foreign body obstruction, or any related to any medication, radiation, or iatrogenic following endoscopic procedures, or a traumatic perforation. Large bowel, again, it can be due to tumors, diverticulitis, infection, foreign body, or penetrating trauma. So the pathophysiology in GI perforation with peritonitis, there is hyperemia and the fluid exudation of fluid into peritoneal cavity. So there is massive shift of fluid from the intravascular compartment into the third spaces, which can lead to hypovolemia and shock. And depending on the extent of perforation, size and location, this can lead to sepsis, systemic inflammatory response syndrome, coagulopathy, multi-organ dysfunction, and metabolic acidosis, depending on the fluid translocation. So on evaluation, we mainly focus on pain, where it is located, type, migration, associated features like nausea, vomiting, constipation, fever, any altered sensorium, history of any prior abdominal surgery, any peptic ulcer disease, inflammatory bowel disease, usage of drugs like NSAIDs, smoking, alcohol. On examination, first we look at the patient's sensorium. If due to any severe sepsis or if the patient has an obtunded sensorium, we should go in the order of airway, breathing, circulation, and airway has to be secured. Any hypotension has to be corrected. So to assess the volume status, we look at the mucous membranes. If the patient is in shock, they can be called clammy peripheries associated with tachycardia, hypotension, tachypnea, and hypoxia. Fever, abdominal examination, look for any previous scars, guarding, rigidity, try to localize the tenderness, which would give us an idea of the area of pathology. And abdominal examination is incomplete without groin genitalia and perectal and hernial orifices examination. So tests, we go ahead with a routine complete blood cell coagulation panel, electrolyte, RFT, LFT, lipase, amylase, arterial blood gas, and lactate level. Imaging, a contra-CT abdomen or a plain erect abdominal radiograph, depending on the examination findings. So initially, we give a vigorous fluid resuscitation because there is a component of hypovolemia due to the fluid translocation. Antibiotics has to be initiated. Then the source of infection or the sepsis has to be controlled with emergency surgery. And any dyselectrolytemia, coagulopathy, or acidosis has to be corrected. And any comorbid conditions also has to be given treatment simultaneously. So the antibiotics, based on the operative findings and degree of contamination, we decide on the antibiotics. Empirically, the patient can be started on a broad spectrum penicillin with a beta-lactamase inhibitor, along with an aminoglycoside and an anaerobic cover. If severe sepsis or a hospital-acquired peritonitis is suspected, carbapenems can also be considered.
So, Dr. Ann, one sec. These antibiotics, what are the general guidelines now for starting antibiotics? The patient is coming from the community. Textbooks are there, Western textbooks, Western data, Indian data. But generally, how do you decide upon the antibiotics in patients who come?
So, in community acquired peritonitis, usually
and peritonitis or any infection, books will mention start that, but there's a lot of resistance and all. So
yes.
Primarily determines what antibiotics you're going to start in your ICU.
So we generally go about with a broad spectrum penicillin and a beta-lactamase inhibitor.
Why do you go along with this? So you go along with this because you look at the flora that is coming to the ICU.
Yes, we usually...
Your ICU caters to a certain population, right?
Yes.
Population, you get the culture reports, so you know what is responding. So all ICUs cannot use piperacillin, tazobactam, because the flora doesn't respond. They come with resistant bugs. Then you have to use carbapenem. So it varies from ICU to ICU. What is the geographical location? What is the population? What kind of bugs they are carrying when they come from the community? So that is the answer to what kind of antibiotics you are using. If anybody asks what antibiotics we use, so that is the answer. It depends on the flora of the community-acquired community patients who come to my ICU. I know what kind of culture sensitivity reports I get. That decides the antibiotics. Of course, it's a framework within which you have to work. For abdominal, will be different. For pneumonia, will be different. The UTI will be a little different. So that's the answer. And the other thing is aminoglycoside. Do you want to use aminoglycoside here?
Here, because the patient is already in AKI, I would not use an aminoglycoside.
Yes. And if you use a carbapenem, is it necessary to have anaerobic cover?
No.
It is not necessary. Carbapenems have good anaerobic cover. The carbapenems you don't need to give any anaerobic. They have excellent anaerobic cover. Okay. Next slide.
Sir, anaerobic cover is required in upper GI also, sir. Upper GI, lower GI.
Yeah.
Most of the time we start for the lower GI, we start. Like stomach and duodenum, still we need anaerobic cover, sir.
Yeah, the flora contamination is less with upper GI, but lower GI is more contaminated with anaerobic, but you have to cover for anaerobic any GI pathology, any perforation, peritonitis.
Okay. Okay, sir.
Okay, carry on, next slide.
So fluid resuscitation has a key role in management because there is massive fluid shifts. So crystalloids are preferred for resuscitation. If there is associated coagulopathy or anemia, also preoperatively, we can use it to correct the coagulopathy. And also there will be, it's going to be an open abdominal surgery. So there will be a lot of fluid loss. So fluid resuscitation is the key thing in these kind of patients. So a definite endpoint for fluid resuscitation has not been described, but still we would like to resuscitate till either the urine output normalizes or the hypotension corrects itself, or when the
lactate starts normalizing or base excess
is correcting.
Normalizing, okay.
Here, what was your endpoint for fluid resuscitation? And
here,
what was the end point of your fluid resuscitation in this patient before he goes to the OT?
So we aimed at a correction of the metabolic acidosis, tried to lower the lactates and also to bring about a urine output of at least 0.5 ml per kg per hour.
What is the problem with using urine output as an endpoint?
Because
it is not recommended to have. This is not correct actually. Urine, kidney is very important. Why urine output cannot be used as an endpoint?
Because that can lead to a fluid overload situation.
Yes. Why? Because he may be in ATN. You don't know.
Yes.
And if you keep loading him, the kidney function will worsen. If the patient has gone into ATN and you keep pushing in fluids, that will lead to worsening of renal function because one, the kidney itself will get swollen. Once the kidney gets swollen, the capsule and the intra-renal pressure rises. So the glomeruli and the tubules get compressed, the GFR decreases. Secondly, the CVP becomes high. And the renal perfusion depends on the difference between the renal artery pressure and the renal venous pressure. The CVP becomes high, the renal venous pressure becomes high. The difference between the renal artery pressure and the renal venous pressure decreases. So again, the GFR decreases. So this is a very deleterious situation, using urine output as an endpoint, and this is practiced widely because, one has to use tools to make sure there is hypovolemia or hypervolemia. One has to have fluid assessment, but definitely normalization of hemodynamic parameters, targeting a MAP of 65, trying to lower the lactate, trying to correct the base deficit to, whatever levels you can, are useful endpoints. Okay. And overall improvement, mentation may be altered, which can improve. So you look at all these things, but urine output is very dicey. Urine output should not be used. Okay. Any comments, Dr. Vikram, sir?
Sir, just want, sir, this one question for surgeon. How emergency is this procedure?
So
is it patient has to be immediately taken up, or do we have some time for optimization?
So preferably as soon as possible. So the more leak is happening, which is causing more contamination and which causes more of peritonitis, it increases more. So again, the contamination is more. Post-surgical wound, since all these factors also plays a role. So before the contamination increases, we prefer to operate him.
But whatever emergency it is, I think pre-optimization is a must. We can't push the patient in a hurry. That is associated with an adverse outcome.
Yes, sir.
Yes, sir. Can we proceed, sir?
Yeah. So anything you want to know, Dr. Vikram, sir? Should we move?
Yes, sir. Yes, sir.
Okay, next slide.
So supportive therapy would include active warming of the patient, correction of coagulopathy, mechanical ventilation if indicated, correction of acid-base balances by fluid management, or if the patient is on ventilator, by ventilatory settings, inotropes and invasive monitoring as indicated, and organ support if it is required.
So why do you need to warm the patient, Dr. Ann?
So in sepsis, there can, because we are
no sepsis here. A patient, post-operative patient.
So massive fluid resuscitation. And
why you use warmers, right? They are hypothermic. So why warm the patient?
So hypothermia can again lead to acidosis, worsening of the acidosis. It can affect the wound healing and also lead to post-op surgical site infections. So,
okay. So it leads to all these things. How does it lead to poor wound healing? So there is vasoconstriction and there is decreased blood supply to the sites.
Yes.
Very important thing. Anything you want to add, Dr. Vikram, sir, about warming and all?
Yes, sir. Warming is a very, very important aspect, especially in the perioperative period. So apart from that, hypothermia itself can reduce the metabolism of all our anesthetic drugs, and there can be delayed recovery is one more thing that is associated with hypothermia.
Okay, next slide.
So the definitive treatment of this would be source control with an exploratory laparotomy, peritoneal lavage, and based on the findings, either an anatomical repair or the resection of the deceased part followed by anastomosing. So in our patient, as soon as he we received him from emergency medicine. Fluid resuscitation was already initiated. From there, we secured wide bore peripheral IV access. Invasive BP monitoring was established. Blood samples were drawn for culture and sensitivity, and empirical antibiotics was initiated. So initially the patient had a low urine output, but he was fluid responsive, and there was improvement in the hemodynamic parameters following a fluid resuscitation, and there was an improvement in the urine output also.
Okay, now just hold it there. Just go back to the antibiotics. So, Dr. Vikram or Dr. Jiju, these antibiotics are okay, but anything else, if the patient is not responding, any other addition of antibiotics or modification of antibiotics or antifungals you would like to consider? Any, Dr. Vikram or Dr. Jiju, anybody can, want to comment on that? Suppose this patient does not respond to these antibiotics.
Yes, sir. We can hike up to carbapenems, and we can include antifungal gram-positive cover. I mean, if cultures are positive for any gram-positive organism, we can include a gram-positive cover.
So actually, the point I'm trying to make here is that enterococci are normal inhabitants of the GI tract. Okay, so this is a upper GI, it's a DU perf. So enterococci are normally found lower down, but the guidelines are broad spectrum. They cover generally perforation. So enterococci needs to be covered in perforation of the bowel. That is very important. Okay. Enterococci need vancomycin. This is something we don't consider, but the newer guidelines all recommend that you should consider covering with vancomycin for enterococci, which are not
empirically only we have to start, sir.
I think you should start, or you can always de-escalate once the patient is improving or you have cultures. The other thing is Candida. So Candida is the normal flora of the intestine. And if the patient is not improving, or if the patient is in shock, bad multi-organ failure, then you should start upfront antifungals. Fluconazole. That's very important. So these two drugs should always be considered: vancomycin for enterococci and fluconazole for Candida. This patient is not that bad. He's responding. You give him fluids, and you have urgent source control. But if there's multi-organ failure, frank shock, then definitely I would start vancomycin and fluconazole in this patient.
Okay.
Next.
So the patient had some background of respiratory infection, so he was nebulized, and then urgent surgical consultation was taken up, and the patient was shifted for an emergency laparotomy. So intraoperatively, a 5 mm into 5 mm duodenal perforation was seen, which was repaired with a Graham's omental patch. There was 4-quadrant peritonitis, and 1.5 liters of ascitic fluid were drained. So, and patient had tachycardia, which persisted, but BP was stable. He was given 3 liters crystalloids intraoperatively, and 600 ml urine was drained. Towards the end of the procedure, patient developed atrial fibrillation with a heart rate of 170, with BP of 110 to 120 systolic. 300 milligram of amiodarone intravenously was administered. The patient was shifted to ICU in view of on ventilator, in view of acidosis and also atrial fibrillation.
So, Dr. N, did the blood pressure drop with atrial fibrillation?
No, sir. The BP was stable, systolic of 110 to 120.
So, if the blood pressure had gone into 80/60, what would he have done?
We would have done an cardioversion, sir. Hemodynamically unstable.
Okay, very good. Now you have given quadron. So, usual dose is what for AF? Quadron dose? Bolus dose?
300 milligram IV, followed by a maintenance dose of 360 milligram over 6 hours and 540 milligram over 18 hours.
See, 300 you can give, but it is a higher dose. Normally 150.
150 followed by, if not responding.
300 is reserved for VT, not just for AF generally. So, what is the problem with giving higher doses of amiodarone?
It can cause hypotension
and bradycardia.
Yes.
That is the thing. So now this patient has renal failure. Does the infusion dose need to be reduced? Does the dose of amiodarone infusion need to be reduced in renal failure? So the dose is not to be reduced in renal failure. Okay, dose remains same because it undergoes hepatic metabolism. What about liver disease? Now this patient may have liver disease. His albumin is low. His alcohol is low. Is alcoholic. So does the dose need any modification, or can you give amiodarone in patients with chronic liver disease?
No, sir. It would cause further hepatic insult. So the dose would have to be reduced in liver disease.
Yeah, so it is metabolized in the liver. So one is it is hepatotoxic. The other thing is the metabolism gets altered. So you can give a maximum for a day in hepatic disease, chronic liver disease.
Okay.
So these are the considerations that we have to be taken into consideration. Now the other thing is amiodarone the drug of choice for atrial fibrillation?
So a rate control has to be attained. So a beta blocker could be considered. Here the patient is already in sepsis and BP is borderline. So
No, BP is not bad. BP is okay. Start pouring urine in the OT. Now beta blocker you said is one drug. Can you give beta blocker in him?
he already has a rhonchi and a chest infection.
Yes.
So
So beta blocker is out. Okay.
Yeah.
So drug of choice is beta blocker. So if you
calcium,
beta blocker, which is the other drug?
calcium channel blockers like verapamil, diltiazem.
Yeah, diltiazem. Huh? So could you have given diltiazem to him?
Yes, sir. Yes.
So if the blood pressure is not dropping, urine not coming, you could have considered diltiazem. Huh?
Yes.
So what is the dose of diltiazem? Bolus dose? Okay, you should know the emergency doses. Huh? Okay. Now, the other thing is, what is there anything in the ECG which can preclude from giving amiodarone? What in the ECG, if you see that, will decide in not giving amiodarone?
QT prolongation.
Very good. So how much should the QTC be when you look at the QTC?
400 to 450 milliseconds.
No, that is not increased. If the QTC is increased, then you do not give amiodarone. But what is the level? How much QTC?
500 and
0.5.
0.5.
Huh? If the QTC is more than 0.5, then generally one would not like to give amiodarone. It can cause proarrhythmias in terms of VTF. Proarrhythmias. So amiodarone should be known to all intensivists because it's very important. You use it all the time. It's an emergency drug. You cannot not know amiodarone. Okay. Any comments, Dr. Vikram? Sir?
Yes, sir.
Any comments on amiodarone?
No, sir. I will proceed.
Okay.
Yes.
Proceed.
So this patient had a new onset atrial fibrillation. So there are signals are generated all over atria and there is an uncoordinated electrical activity. So the AF can be divided into paroxysmal, persistent, and permanent. So this paroxysmal is what happens perioperatively used due to an acidosis or a volume shift. So persistent is when it persists for more than 48 hours and permanent is more than 1 week. So this atrial fibrillation can lead to LV dysfunction, atrial stretch, and which would cause remodeling of the atrial fibers, making it resistant to therapy in case of a permanent situation.
So can you said LV dysfunction and atrial stretch. So can you get arrhythmia AF from the right side? RV dysfunction and right atrial stretch. So it can occur from that side also, huh?
Yes.
And he's a COPD patient, so the right side is likely to be affected rather than the left side. Of course, he's diabetic and also left side can be affected as well. So, if he's a COPD patient, he has said, you have said AF, but you have not put the ECG. What is a common arrhythmia, supraventricular arrhythmia in COPD patients? Commonest arrhythmia, generally, which is seen mainly in COPD patients.
There's atrial fibrillation because...
No, atrial fibrillation. What is the other one? Atrial fibrillation you have said, but you have not shown the ECG, whether it was atrial fibrillation or something else. What are the other supraventricular arrhythmias?
Atrial flutter, then
what else?
AV nodal re-entrant.
Multifocal atrial tachycardia. So multifocal atrial tachycardia is particularly common in COPD patients. And the supraventricular arrhythmia. So, sometimes if you look at the monitor, you will not be able to make out whether it's AF or multifocal. You need a strip. So these errors can be made. The treatment is by and large the same because the supraventricular arrhythmia. But respond well to beta blockers and diltiazem. But definitely you could have AF because AF is common in the elderly in the post-operative setting. Okay. Carry on.
So the risk factors in this patient, risk factors in general for new onset atrial fibrillation in the preoperative phase are conditions like obesity, hypertension, hypothyroidism, rheumatic heart, any structural or ischemic heart disease, COPD, pulmonary embolism. Intraoperatively, changes like MI, acute volume shifts, excessive volume shifts, pain, hypotension, metabolic disturbances, hypoxia, and the stress itself precipitated by the surgery. Post-operatively, also conditions like volume overload, hypotension, inflammation, and dyselectrolytemia can also precipitate an atrial fibrillation. So mainly the goals of treatment in a patient with AF is to reduce the thromboembolic risk, anticoagulation, rhythm control, restore and maintain sinus rhythm, because the atrial kick is important for maintaining the cardiac output, and also rate control to give time for the ventricles to fill. So this patient was received back from surgery. We continued the broad spectrum antibiotics, and for the atrial fibrillation, maintenance dose of amiodarone was given. Fluid resuscitation was continued. And an improvement in the urine output, as well as improvement in the serial RFT, was observed over the subsequent days. And for analgesia, intravenous fentanyl and paracetamol was given. A serial arterial blood gas twice to thrice daily was done initially, which showed resolution of metabolic acidosis in the subsequent days following surgery. So this patient had an elevated serum creatinine. So the rifle criteria, there are 5 stages: risk, injury, failure, loss, and end-stage renal disease. In the first risk stage, the creatinine is 1.5 times the baseline, with a urine output decrease of less than 0.5 ml per kg per hour over 6 hours. In the injury stage, creatinine is double the baseline, with a decrease in urine output of less than 0.5 ml per kg over 12 hours. In the failure stage, creatinine has jumped to thrice the normal value, with the urine output of less than 0.3 ml per kg over 24 hours. In the loss stage, there is complete loss of renal function for more than 4 weeks, and end-stage renal disease for more than 3 months is the.
So, Dr. Ann, one thing I would like to tell you: this rifle criteria is actually, it was used, but now the KITCO criteria is used. The latest classification for AKI is the KITCO criteria, and the rise in creatinine is all correct, but it is not classified as risk, injury, failure. It is stage 1, stage 2, and stage 3, and stage 4. So creatinine values are all right. So what you have written, 1.5 to 2 times, 2 to 3 times, and more than 3 times, and more than 4 times. It goes like that. KITCO classification: stage 1, stage 2, stage 3, stage 4, and also urine output is as used for the criteria. And if there is a rise of even 0.3 in the creatinine acutely within 6 hours, that is stage 1. Okay, so the rifle and all were used earlier, but now it's the KITCO classification, the latest classification for AKI. Should go through it.
So the acute kidney injury can have a pre-renal, renal, or post-renal causes. So pre-renal is mainly impaired perfusion due to dehydration, sepsis, or anything that would cause hypotension. Renal is causes associated with the renal parenchyma, like the glomerulus or the blood vessels or tubules. And the post-renal is usually any obstructive causes in like renal calculi or BPH or malignancy of the lower genital tract, which would cause an obstructive uropathy.
So, you have mentioned drugs as a cause of renal failure, right?
Yes, sir.
So, can piperacillin tazobactam cause renal failure?
Yes, sir. Piperacillin tazobactam also has a renal elimination. So, in a patient with AKI, we should give the renal corrected dose according to the.
No, that is all right. Can it cause renal failure, AKI?
It does not cause as such, but
So, piperacillin can cause, all penicillins can cause by virtue of causing interstitial nephritis. Piperacillin can lead to AKI.
Yes.
Does the dose of metronidazole have to be decreased in AKI?
Metronidazole dose remains the same, sir.
Okay, unless the GFR is less than 10, metronidazole dose remains same.
Yes.
Next. Yes, what is this now?
So the if it's a pre-renal AKI, the treatment main thing is to treat the underlying cause of the hypoperfusion, avoid further insults by preventing nephrotoxic drugs, hypotension. The volume status has to be restored. A dialysis is indicated only when there is a refractory hyperkalemia or a pulmonary edema, uremia, acidosis, or if there is a dialysable toxin. So this is the serial ABCs.
Just go to the last slide. So, out of this, they are the classic conditions or criteria, but uremia is very important. So,
Yes.
even if you don't have hyperkalemia and acidosis, the trend now is, or the emerging indication is that once the urea touches 150 to 200, then you dialyze the patient. Even if there is no hyperkalemia, no significant acidosis, no fluid overload. Because early kind of dialysis, whether you want to call it early or not, helps in overall treatment outcomes. But once the urea touches 150 to 200, one has a tendency to dialyze the patient. Okay. Next.
So the serial ABCs, so the preoperatively, the patient was in acidosis with an elevated lactate. So in the further serial postoperative ABCs with fluid resuscitation and also correction of the primary insult, the patient's acidosis improved in the subsequent post-op days. And the urea creatinine value also improved over post-op over the post-op days. The patient, the 143 is the day on the day of surgery, and in the subsequent days, the patient it showed an improvement in urea as well as creatinine and an improvement in urine output. So the patient was managed with antibiotics. Then other supportive therapy like stress ulcer prophylaxis was done with intravenous pantoprazole. Then the patient was, because he was a COPD patient and he was on ventilator, nebulization chest physiotherapy was initiated. So in the initial days, the patient was kept nil per oral with a continuous rise tube aspiration. As the ABG and the renal function along with the platelet count improvement was noticed, and the patient was extubated on post-op day 2. Following which the patient was started on incentive spirometry and bedside mobilization. Because he was a diabetic, his blood sugar control was to be managed with short-acting insulin, but since he was NPO and his nutrition status was not adequate, the sugars were more or less under control. And once the platelet count improved to more than 1 lakh, we started on unfractionated heparin 48 hours post-surgery.
So now, the glycemic control, he was on metmorphin and I think you said glibenclamide or something. What did it do with them? Were they continued or were they stopped?
They were stopped, sir. The patient was kept nil per oral, so none of the medications were given orally. And
Okay.
because he was NPO...
If he could take orally, would you give him oral hypoglycemics?
No, sir. Metformin again would cause lactic acidosis. So and also in the immediate post-operative for controlling glycemia.
Once the patient gets admitted in the ICU, all oral hypoglycemics have to be stopped.
Yes.
Because of various reasons, the diet is variable. You do not know he can be predisposed to hypoglycemia. So that is a cardinal rule. Do not give oral hypoglycemics in the ICU, only insulin. Okay.
Yes.
Now you have said the sugars never went high.
No, it was more or less normal because he was
you get hyperglycemia or hypoglycemia in such patients of sepsis and diabetics and sepsis.
So in this, we would have expected hypoglycemia, but his sugars were
So in sepsis, do you get hyper or hypo?
Hypo, low blood sugars.
You don't get hyperglycemia in sepsis? And is diabetic also?
Yes, sir, that is possible.
So you can get, generally you get hyperglycemia because of stress. Because of stress hormones and cytokines, you get hyperglycemia.
Okay.
Hyperglycemia does occur if the patient is not fed properly or has pre-existing malnutrition. And the etiology is because of cytokines and because of stress hormones.
Okay.
Next slide.
So this patient had a primary anatomical repair, and so he was initiated on feeds around 7 days post-surgery. So if the surgery had involved an extensive resection anastomosis, so we cannot initiate an oral feeds. So to take care of the nutrition, TPN would have been required. So this is just a note on TPN. So 25 to 30% of total calories in TPN is a lipid emulsion. has proteins, essential and non-essential amino acids, carbohydrates, which are contributed by dextrose, and also calcium, magnesium, phosphate, phosphorus, and trace electrolytes are also present in TPN. So the solution, it's initiated slowly via central venous catheter, and depending on the patient's tolerance, we titrate the dose of TPN. So patients on TPN can develop severe complications, and we should watch out for hyperglycemia and also sudden discontinuation, which can lead to hypoglycemia, electrolyte abnormalities, calcium, magnesium, phosphate, everything has to be repeated. And also parenteral nutrition associated cholestasis, refeeding syndrome in patients who are chronic alcoholic, and also who have been NPO for more than 1 week. So these kind of complications can happen. So in our patient, he was initiated on oral feeds 1 week after surgery, and once he the bowel rest and period was over, so he was never initiated on TPN.
Was he given TPN or not?
No, he was not. He was not.
So you have written he was started on TPN?
No, sir, he was not started on TPN. This is just a not on TPN, which has been in case there was an extensive bowel resection involved.
Okay, so you just mentioned. So what kind of feeding did you give him?
So in the initial 7 days, he was kept NPO, and following which slowly water was started orally, followed by a liquid diet. And
when was the liquid diet started?
Sir, he was shifted. Patient was shifted after extubation. I think 4th day was shifted to HDU. So I think surgeons will be able to.
So Dr. Jiju, what are the feeding recommendations in terms of enteral and total parental and bowel surgery?
How many days you want to keep NPO, Dr. Jiju? A perforation who has been operated with a omental patch. So
Yes,
how many days is the recommendation?
5
No,
days.
let us not talk about omental patch in a patient who undergoes GI surgery.
Okay.
Surgery. Okay. So what are the recommendations for feeding enteral and total parental? When do you give enteral and when do you give total parental?
So TPN is usually given for patients who are kept for NPO at least for 7 days or more. Those patients only will be starting on TPN. Otherwise, we'll be starting in this one's enteral only. So usually,
So I think that is a very important point, that TPN is not to be started immediately. First, you try, if the bowel allows, you try oral or enteral. And if you can wait, you should be waiting for at least 7 days before starting TPN. There is no untoward outcome with this. This is very clear. 5 to 7 days you can wait without any nutrition in these patients. The exception is if the patient is malnourished, malnourished. There you have to start TPN early. And malnourishment is assessed by Nutrix score. We don't do this. The one thing we don't do is we do not chart the weight and height of the patient. Some kind of a BMI should be there when we record the details in the patient's history. The other thing is the Nutrix score should be done in all patients. And if the Nutrix score is more than 4, that means he's at high risk for malnutrition. And one has to consider these kind of things like starting TPN early. So you're very right. TPN should not be started unless 5 to 7 days have passed without any kind of nutrition, or the patient is malnourished at the outset. That is another indication. The patient is cachectic or poorly nourished, then you have to start TPN early. There you don't wait. That's very important. The other thing is, so do you use TPN, Dr. Jiju?
Yes, sir. Like if you're planning for a big procedures, like so if you're planning for a Whipple's procedure, those kind of patients and who are already.
What kind of complications can you anticipate with TPN?
So like she just examined like refeeding syndrome and electrolyte imbalance. And other thing is related to the stents. There can be misplacement of the stent, embolism can happen, pneumothorax, these kind of complications can also happen. And one more thing is we have to consider about the cost factors. And some of the patients won't be able to afford these kind of treatment, putting central line and again TPN, they won't be affordable. So we consider that also.
So the complications she has mentioned very clearly, they can be refeeding syndrome. So that is not specific for TPN. That can occur with any patient who is malnourished, who is starved, who is not having good nourishment. And these patients can go into refeeding either with enteral, oral, or with TPN. And refeeding syndrome manifests with electrolyte deficiencies within 3-4 days of starting your feeding. And electrolyte deficiencies occur because there is increased cellular consumption of electrolytes, because there is increased cellular metabolism. They have suddenly you start feeding them. So there's energy generation in the cells, which consumes electrolytes. So there's a shift of intravascular to intracellular electrolytes. And there's a release of insulin, and insulin has a tendency to shift electrolytes from the intravascular space into the intracellular space. So there's a fall in phosphate, there's a fall in potassium, and there's a fall in magnesium, and you can have arrhythmias and respiratory muscle weakness and all these things. And the treatment of refeeding syndrome is you cut down on the caloric feeding drastically. You give only 25% for a few days till it stabilizes, and then you resume gradually. So that is refeeding syndrome. The other thing is you can get hyperglycemia. Now, why do you get hyperglycemia with TPN? So there are 2-3 reasons. One, with hyperglycemia, with the TPN, you tend to deliver more calories than with enteral. You know, enteral, there's interruption. Feeding is going on, something will happen, and this, that, so it gets disconnected. But you tend to deliver more calories, one. Second, the insulin levels are lower with TPN. Because with TPN, the gut axis is not used. So enteral, the gut axis is used. So the gut endocrine system is more active, and there is a better regulation of the sugar levels with enteral as compared to parenteral. And third is, you know, when you use TPN, the patient is more sick generally. And there is a greater amount of these hormones, stress hormones being released, cytokines being released, which lead to hyperglycemia. So that is the reason why hyperglycemia is more common with TPN. Now the thing is, question that comes to mind is TPN harmful as compared to enteral? So the answer is no. Earlier it was thought, and studies showed that TPN was more harmful than enteral. But subsequently it was seen the harm came from mainly impaired glucose control. If you control the glucose properly, and if you change the lines every day, the lines have to be changed every day, and the sugars have to be managed. So these two factors reduce the incidence of infections, and it was the increased incidence of infections which was causing the problem. So TPN, if managed properly in terms of its sugar, in terms of line care, is as good as enteral. Okay. Now coming to the other thing, hypoglycemia does not occur suddenly. I don't agree with that unless you are giving insulin. So I don't know where you got that from. Then coming to serum electrolyte abnormalities, so daily they have to be monitored, and hypophosphatemia is very common. Hypophosphatemia is very common because glucose levels go up, there's increased insulin, and there's a shift of phosphate from the intravascular space into the intracellular space. So hypophosphatemia is very common with TPN. Now coming to Wernicke's encephalopathy. So Wernicke's encephalopathy is actually thiamine deficiency. So this occurs in alcoholics or previously starved patients, and Wernicke's encephalopathy can also occur in the ICU if you do not supplement thiamine. You know, patients sometimes stay for months and they get TPN, like you said, Whipple's and all can stay on, or acute pancreatitis go on for a few months. So Wernicke's encephalopathy is recognized by the cardinal symptoms of what the triad, which is confusion, ataxia, and eye signs. Eye signs will be in terms of ophthalmaloparesis and nystagmus. So all of them may not be there. You'll get some eye signs because confusion may or may not be elicitable. Ataxia you won't get. Okay. So if the patient's sensorium is normal, suddenly he'll become confused and he will get some kind of eye signs or nystagmus. Now, other thing is parenteral associated cholestasis. So why do you get parenteral associated cholestasis? It generally occurs after 3 weeks of TPN. There are two reasons. One, the ingredients in TPN lead to hepatocellular dysfunction. Second is that, you know, when there is parenteral nutrition going on, the gut and the liver are at rest. So the biliary secretion does not take place. So there is a impairment in the hepatocellular function leading to cholestasis. Okay, but this occurs only after 2-3 weeks of TPN, not before that. So these were some of the things I wanted to say about TPN. And the very important message about TPN is use TPN when required. Patient should get adequate calories. A total deficit of calories of 5,000 in the ICU stay is clearly associated with increased mortality. And it has been seen that most of the patients do not get the required amount of calories. So that was TPN. Anything you want to add, Dr. Vikram sir or Dr. Jiju sir?
No, sir, you have covered. I think triglyceridemia also is one of the...
Yes, definitely. Every 3-4 days, triglyceride should be monitored. Absolutely.
Yes.
Absolutely. And the other thing is, now just we'll come to the end before we make some comments. So Dr. Jiju, what do you think was the cause of DU? You had a look at the DU. You must be able to make out what is the cause of DU by looking at it.
Yes, so we are suspecting mainly because of his alcoholic history. But studies also say usually this one alcoholism is not a cause, but usually gastrin secretion is increased. So that
No,
can
alcoholism does not cause general ulcer. I don't agree with that. H. pylori ulcer is there, no? H. pylori.
Yes, sir.
Commonest cause of DU is H. pylori and NSAIDs. 90% is H. pylori and NSAIDs. There's no NSAID intake. So it has to be H. pylori.
Yes, sir.
Okay.
Yes, sir.
This was H. pylori. Huh?
Yes, sir. Looks
Now,
like that. Yes, sir.
Yeah. You agree, Dr. Vikram?
Yes, sir. H. pylori is one of the most common causes. Dr. Jiju, any workup was done to diagnose this H. pylori infection in the post-op period?
No, so we were planning on doing a scopy, but patient got discharged and we thought we'll do it at a later stage, sir.
Did you start him on H. pylori prophylaxis treatment?
No, sir. We had just put him on PPIs, and initially we had kept him on Nilparora, and continuous aspiration was there. And post surgery on day 5 days we kept him NPO, and from day 6 we started him on oral SIPs, sir. And then next day this one, sir.
But I don't think there is harm in giving a treatment for H. pylori even without doing an endoscopy or your breath urease test.
Yes.
No, even if you have sent the sample, no, you can look at the histopath sample. That can show if you tell and all look for H. pylori, they can tell you histopath sample.
Yes, sir.
Okay. So routinely all duodenal ulcers, you don't give H. pylori this one prophylaxis for your patients.
So usually when they come back for review, that time we'll start, sir. Like post surgery, we'll discharge once, and when they come for follow up, that time we'll start. Till then, we'll tell them to control their diet, sir. Like only soft diet.
Actually, it's very difficult to give it immediately because it causes a lot of distress. The drugs, you have to take a lot of pills and all that. It's not so easy. So I think that's okay. But you can when he comes back. Now the other thing is before we close. So there's a condition called post-operative SIRS. So anybody wants to comment on this? The question for everybody, including the audience. So if anybody wants to comment on what is post-operative SIRS, systemic inflammatory response syndrome. This is a very interesting entity, and it's quite a thing. So we should know about this. And this is something I've seen which people don't know. That's why I've raised this question. Anyone in the audience wants to answer? So post-operative systemic inflammatory response syndrome is SIRS actually, which is caused by surgery. Because when you do surgery, you are cutting tissue. And when you cut tissue, you create inflammation. And when you create inflammation, you lead to release of cytokines. So that elicits a systemic inflammatory response syndrome. And this systemic inflammatory response syndrome can manifest with hypotension, with single organ failure, with renal failure, or with multi-organ failure. Patient will come out of the OT and his blood pressure will never normalize, and his urine output will not pick up, and you will realize he has gone into AKI, or he'll develop some other organ failure. So this often masquerades as sepsis. One would think that he has sepsis, but he does not have sepsis, he has SIRS. So this is very important to realize post-operative SIRS, this entity, and one must not confuse it with antibiotics and sepsis. So that was all I had to say. So
how do you treat it, sir? Symptomatic, supportive only.
Yeah, supportive. The thing is, this is not something else. One should pick it up, and then treatment is supportive. It has abate within supportive treatment. If the surgery has been done, cytokines will wash away. So one has to realize that one should not do wrong treatment in terms of giving a lot of fluids. So because the kidney has gone into AKI, if you keep pushing in fluids, you lead to further worsening, or you give unnecessary antibiotics, you lead to resistance and further nosocomial infections, etc. So one must realize that this condition is there. Of course, the other causes for post-operative hypertension, but this is something I've seen myself. Patient comes out and he'll have hypertension persisting, organ failure, and people will just start putting in antibiotics, higher antibiotics and antifungals. So any comments, Dr. Vikram, sir?
No, sir. I think it was a very good presentation by our SR, Dr. Ann, and very informative discussion. We have discussed everything, including the basics, how to approach an acute abdomen. It was a very good learning experience for me, sir. I'm sure others also would have benefited from this.
So, thank you, Dr. Vikram, sir. Dr. Jiju, any comment?
No, thank you, sir. We also had a good input, sir, like post-surgery and pre-surgery stabilization of the patient, and post-surgery, all this, how to manage the patient. We had a good discussion about that also. Like, it was very informative for us also.
Okay, thank you. Dr. Any questions, any clarifications you want?
No, sir, no.
No questions?
No.
You can ask any questions, any doubts? Okay. So I think before we close, I would like to thank Dr. Vikram sir for getting this organized, and of course Dr. Moses. So Dr. Charles Moses was supposed to be here, but unfortunately got held up. So
Yes, sir.
to thank Dr. Charles Moses for getting it organized and Dr. Vikram sir for organizing it. I thank
you, sir.
Dr. Ann for doing this wonderful presentation, really lovely slides, and the time and hard work that she has done with this. And I would also like to thank Dr. Jiju for his surgical inputs, and thank Dr. St. John's Medical College, the Critical Care and Surgical ICU department, for their wonderful presentation and contribution for teaching our intensivists and all the young doctors in critical care and anesthesia. Thank you so much, Dr. Vikram and everybody.
Thank you, sir.
Thank you, sir.
Thank you, sir.